Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. Hello, listeners. Happy Monday and welcome back to the Heart of Healthcare podcast. Today, I'm with my co-host, Michael Esquivel, to talk about the leading cause of death in the United States, heart disease. And we'll talk more generally about heart health and where digital health comes into play. Our guest is one of my portfolio company founders, Dr. Jeff Wessler. Jeff is a cardiologist and the founder CEO of Heartbeat Health, which is the nation's first and largest virtual first cardiovascular company. Jeff, welcome to the show.
Thanks, Hallie. Nice to be here, and nice to be here with you too, Michael.
Likewise, Jeff. Excited to talk about this incredibly important topic.
Yeah, I mean, just on that note, I feel like heart health is under-discussed in the digital health world, and there are relatively few digital health startups really geared towards cardiovascular health compared to, say, diabetes. I did notice there's now a cardiovascular digital health journal, which is interesting. It shows that practitioners are interested in this intersection of digital health. But Jeff, just maybe give us an idea of why you think digital health has kind of ignored this space given the importance and prevalence of heart disease.
It's interesting. I think when we first started, maybe 8 years ago now, it was pretty clear that everyone, when pitching their digital health ideas and companies, would say their condition or disease state was the most important. But I've always felt that cardiology, cardiovascular disease, heart health really was the most important. And I think the stats truly don't lie. It's, as you said, the leading cause of death. We've got 1 in 3 Americans will have cardiovascular disease face them in a really critical way across their lifetime. And it is this burden that, frankly, is overwhelming when you start to get into condition sets. And part of the reason for that is it's more or less an umbrella condition that includes many of the other things that, you mentioned diabetes. And I think we'll probably spend a little time talking about cardiometabolic, but the relationship between heart disease and all of these other important categories like heart failure and coronary disease and stroke and arrhythmias and diabetes are all in that same category. And it's led to this just in somewhat overwhelming disease category, frankly.
Yeah. So Jeff, why isn't it measured more often? Why aren't we talking about it? I have my theories. And I struggle. Maybe heart disease is a slow progression, so it's not top of mind like some of the other chronic conditions. But why isn't it top of mind? I mean, I think about all the data I track. It isn't one that I'm hyper focused on. So curious what.
But probably more focused on than the average consumer.
Fair enough. I'm obsessed with my health metrics, but when you think about metabolic health, it's sort of. I guess there's not a one indicator kind of metric, or maybe there is, and I'm just not tracking it closely enough.
Yeah, I think a couple of things. First of all, I think the digital health space is a little different from the health space and healthcare space at large. And I do think healthcare has been identifying, managing, and thinking about heart health and heart disease maybe longer than any other condition out there, with the exception maybe of infectious diseases. And so it was not one of these new disease states to really get a bump when digital health and technology and innovation started becoming part of our active conversation, because it was already, sort of one of the founding conditions. Having said that, I do think that's changing pretty readily right now, because we have a whole new wave of prevention and early lifestyle wellness style interventions. And heart health is, I think, one of the core focuses or foci of that, along with mental health and aging and Alzheimer's, dementia. So I do think it's coming front of mind in the so-called consumer, direct-to-consumer mode in a new way, even though it's been part of our landscape in traditional healthcare for many decades.
Okay, so I've had this one question I've struggled with for a long time, and I finally got a cardio expert. And everybody's different, but is a lower heartbeat per minute a better thing than a higher heartbeat per minute, all things being equal? And what does it mean to have a lower heartbeat per minute?
So classic doctor answer is it depends.
Of course.
Come on.
You must have gone to law school. Jeff, did you go to law school and not medical school?
Right, exactly. So in general, all things being equal, assuming that it is not a pathologic or a dangerous cause of a low heart rate, then a lower resting heart rate is a good sign. It's a sign of cardio health. Your heart, it's important to remember the heart, unlike many other organs, it's a muscle. And so the more that muscle is exercised and trained, then the stronger it's able to function. And that equates to a lower heart rate that's needed to pump the same amount of blood throughout the body to maintain all your other organs. So resting heart rate, a lower resting heart rate is a good sign and is usually a sign of good conditioning.
And Michael, given how much you work out, you must have a low resting heart rate. You have good cardio.
I'm typically in the 40s. My resting heart rate tends to be in the mid 40s. And my Oura ring says it every morning. I see it between 43 and 48. So
mine's in the 60s. I need to catch up.
Yeah, that's pretty good. Michael, yours I think is getting to that. Famously Lance Armstrong had a resting heart rate in the 30s, and it's funny. Since I've been doing heartbeat, I get a lot of rhythm monitors, sort of new devices people are trying and want to send me to look at. So I probably wear a heart rate monitor or a rhythm monitor more than like any other human on the planet.
Do you wear an Oura ring?
I have stayed away from Oura rings.
We want to know why, because so this year, like recently, Oura launched a feature. Michael and I are both wearers. That is heart health feature. And they actually like quantify it. So it says your cardiovascular age compared to your actual age. And from what I understand, most people actually have lower cardiovascular ages. And I don't know if it's self-selection, the type of people who wear the Oura ring. Michael, I'm sure yours is like 15 years lower. Mine is 7 years lower.
14 years from peak level, 14 years younger. So I like to joke with my wife. She's really rocking the cradle because I'm 14 years younger, according to Oura.
So tell us there's like this thing called heart age, or what Oura calls cardiovascular age. Like, what is that? And how is that different from chronological age and how many times we go around the sun?
Yeah. So I'll give you my perspective on it. And I think first, there are a lot of these heart health metrics out there. Very few of them have been validated in what any of us would, I think, consider rigorous clinical trials or clinical studies. So a lot of it is, I think, takes interesting data points, tries to map it to a population, and then determine causality, which is somewhat dubious, but might be able to provide some insights that could be valuable. And those insights are basically, how is your heart performance? How does it perform when you're resting? How does it perform during exercise or stress, which are somewhat some shades of the same thing? And are there any indications that there's something dangerous going on? That's different from chronological age, which is a counter that starts when you're born and continues until you age and die, that is objectively measured and doesn't put a lot into what you do to modify your health over time. So as you become on an exercise and dieting kick and are in the greatest shape of your life, your chronological age doesn't change, but your cardiovascular health or your heart age may change and may adjust and improve. So that's a good thing. Yeah. It's good to have an ability to show that working out this core muscle is beneficial for overall health. And I think the jump there is that heart age often is what can accelerate or slow your chronological demise, as it were. And therefore, it's an important one to pay attention to.
Yeah. We have a lot of folks like ourselves that are working around the clock, stressful environments, founders, investors, etc. I feel like they want to know about stress and heart health. I want to know about stress and heart health. Like, if we are in a high stress environment every single day between work and home and the stresses of raising families and caring for aging parents, what is that impact, if any?
So there is definitely an impact, and it is, unfortunately, it's exactly what we think, which is higher stress environments do lead to worse cardiovascular heart health outcomes. This is one of those areas that's been studied quite rigorously, and there were a few landmark studies in the last decade that demonstrated that both basically behavioral outcomes, so stress and depression, or anxiety and depression, people who are facing those issues do demonstrably worse in cardiovascular outcomes. They have earlier heart attacks or MIs. They have more rates of arrhythmias and MIs and heart failure. So why is that happening? I think there are a lot of hypotheses now that are coming to light that inflammation may be one of the key core drivers of that. And inflammation is present all the time. Sometimes inflammation is quite beneficial to your body, but chronic levels or low levels of inflammation when you're not needing it to fight infections can take a toll on all the healthy organs of your body. And the heart is one of the prime targets where if you're chronically stressed and chronically have high inflammation, then you'll see the heart function less well.
It seems, Jeff, I mean, that seems to be the focus so much. Inflammation is really the killer in the long run, and it affects not only the heart. I'm sure you'd note that it affects other organs and has lots of downstream effects, which are quite negative. So the obvious question, I know Hallie was chomping at the bit to get into this, is inflammation and GLP-1s. Right. It seems to me that as a non-medical person, for goodness sake, the lawyer in the room, if you will, here, these GLP-1s seem to be what seems really exciting about them to the non-medically trained mind is that they reduce inflammation. And so is that what you're seeing? Is that the research you're reading, the work you're doing at Heartbeat? Is that a simplistic way to look at it, but a fair way to look at it?
So I'll say this. First, I completely agree these medications are changing the way we sort of think about the paradigms of disease management. GLP-1s inherently are not an anti-inflammatory, but inflammation is one of their mechanisms of action. There are lots of drugs like that. Statins, as an example of a heart medicine, is not an anti-inflammatory, but one of its positive mechanisms of action is anti-inflammatory. So and then I'll say the counter to that is there are plenty of anti-inflammatory drugs that are not good for inflammation or are not good for cardiovascular disease or weight loss or diabetes. So it's not as simple as anti-inflammatory drugs are good for preventing heart attacks, nor is it as simple as the mechanism of GLP-1s improving the heart is inflammation. But that's part of the story for sure. And what I'll say as a starting point on GLP-1s, my strong now and increasingly getting stronger each month, it seems, is that GLP-1s are probably one of, if not the best cardiac drugs, heart drugs that have ever existed and ever will exist. And One of the main reasons for that, I think, is because they're the first and only heart drug that patients actually want to take because they have this amazing side effect of weight loss. We've never seen a drug like that before where adherence is actually beneficial because of one of the side effects of this drug.
That's so true.
That's so true.
It really is. I mean, are you seeing more cardiologists actually prescribing GLP-1s, including the ones that you work with? So you can answer that question. I saw a headline that said something like 40,000 heart attacks a year could be prevented with GLP-1s. Is that true?
Yeah. So first, yes, cardiologists prescribe this all the time. Right now, there are two companies making these drugs. One of them, Novo, had cardiovascular indications listed last year when the first studies came out that showed that it is beneficial for cardiovascular outcomes, not just diabetes and weight loss.
And Jeff, was that Mounjaro?
No, that was Ozempic and Wegovy, Novo's drug.
Oh, Novo's drug, sorry.
Mounjaro or Zepbound is Lilly's drug. The same studies probably will be presented in the next year or two. And so we expect it to be a class effect that it will show the exact same outcomes. So cardiologists prescribe these not only for patients who have diabetes or obesity and have cardiovascular disease, in which you prescribe it and then all three of those things get better, but also now for cardiac patients primarily. And the results are the same level of amazing. And then Remind me, what was the second question?
Oh, the headline that said 30 to 40,000 heart attacks could be prevented.
Yeah. So right now, we think there are about, this will sound ridiculous, but 50 million Americans that would qualify for GLP-1s right now who are not taking them. And there's no question to me that if all of those in need got them, then the rates of heart failure, heart attacks, stroke would be going down by the tens of thousands, like literally
Wow.
No question in my mind. The problem is we as a system need to figure out how to get it to patients who will benefit from it, what to do with how long you're supposed to be on, how to titrate them off. And those are some pretty real unanswered questions right now.
Yeah. I mean, this is like the most American story. Like we've tried to focus for so long on prevention and getting people to eat right and exercise. And it's been, behavior change is just really hard. And we've been waiting for this silver bullet. And do you think the GLP-1s are it?
Yeah, I certainly think they're the start to it. I also think there are a wave of GLP-1 like medications coming out in the next decade. And so this space, which has now more or less been coined the cardiometabolic space, which is basically saying there's a continuum of disease from metabolic disease like diabetes to cardiovascular disease like heart attacks. These are on the same spectrum, the same patients, the same physiology, the same way you progress. And so let's stop siloing them into different conditions and have different providers and groups and companies treating them, but let's treat them together. So GLP-1s have done a nice job of unifying that landscape and, to your point, have really tipped the bucket for prevention so that we now have patients by the thousands coming and asking for these meds, which could easily be painted as preventive cardiology meds instead of weight loss meds. And we've managed to figure out how to get people to want them directly, which is just incredible to see.
What does that mean for med schools, medical training, stepping on each other's toes? If everybody wants to be the one managing the prescription for their patients, how do we decide where this lives within our healthcare system?
Yeah, I think there's a framework for this, so I don't think we have to relearn this, in that primary care really is the quarterback of, still, and should be the quarterback of most of preventive care in this country. And when the issue with primary care, one of my big issues is just resourcing. There's only bandwidth to do so much in so little time. And so I do believe that GLP-1s will be one of those cardiac recommendations that will be the equivalent to taking a statin if your cholesterol is high enough, or taking an aspirin after you've had a cardiac event. And it will be at that level where primary care can and should be managing the majority of the early preventive patients. And then as you progress or patients get sicker, then they sort of graduate into cardiology care.
I mean, I have a doctor friend who likes to refer to GLP-1s as the antibiotics of the 21st century. And Dr. Florence Commentator loves to use that phrase. And it, as I continue to read more and more in both the media and in relevant journals, you sort of see these incredible downstream effects that it starts with insulin resistance and, hey, you've got a diabetic or pre-diabetic problem, and now we're seeing all of these downstream effects. What's interesting, Jeff, at least in some of the popular press that I've seen, the Ozempic versus Mounjaro seem to have slightly, I mean, maybe it's only because of the studies that they're being run against, but seem to have slightly different downstream impacts.
Yeah, so yes, they are different. They're different strengths is the easiest way to say it. And Mounjaro is a little stronger than Ozempic right now. What happens downstream is just being started, that work now. So it really is too early to tell. And part of that is that, number one, there are very different populations taking it. And so looking at a group using it for weight loss is very different than looking at a group of diabetics, which is very different than looking at a group of cardiac patients. And so we really do need to, and these studies are being done, invest in the work to say, when should you titrate off? What are some of the effects? Like lately, there's the effect of bone density and bone mass or muscle mass going down. Yeah, that's a potentially serious outcome of these that needs to be studied pretty rigorously to figure out what needs to be done about these.
Okay, we've covered a lot of GLP-1s. I'm going to change the topic for us. You run the largest virtual first cardiovascular company. Remote monitoring has to be a big part of what you do.
Yeah, I'm glad you asked. Let's talk about remote monitoring. So there are different ways. Remote monitoring means different things to different people. Remote patient monitoring is a category that actually exists across a CPT code, or a billable Medicare code, where you can send a patient a device to their home, which is most commonly a blood pressure cuff and or a scale that will track a certain metric like blood pressure or weight, and you have to track it for 16 data points a month in order to get credit in order to bill through. There's been a wave, like a large wave of groups and companies going after this remote patient monitoring market in order to be able to monetize the work of managing somebody's vital signs from home. I have become, through our work at Heartbeat, quite skeptical of this landscape, not because I don't think there's value in the remote monitoring, but in that the majority of that market has been built around patients who really don't benefit from the care. And that the people who really need remote monitoring, i.e. the care from home, are those people in whom it's very difficult to connect a Bluetooth set of devices and get the requisite number of readings every month and get that data sent back. So at Heartbeat, we actually have taken a somewhat of a contrary viewpoint on remote patient monitoring, which is, number one, we will prioritize manual monitoring instead of fancy connected devices. So we spend a lot of time up front teaching our patients how to check a proper blood pressure, what that blood pressure means with respect to their conditions, when to check their weight, how to appropriately use a scale to check your weight if you've got heart failure, and then what to do with the numbers. If your blood pressure is high, if your weight's gone up a pound, what to do with your medications, when to call in, how to manage that on your own. There aren't a lot of billables that come out of that, but there are a lot of patient outcomes and improvement in care that comes out of it. And so to me, that builds to the point that it's the care that's really needed, not the creating smart workflows that are going to collect enough data points to create a billable event. And that's the stance we've taken with remote patient monitoring at Heartbeat.
My health plan actually directly sent me a device called Hello Heart, which I'm sure you're familiar with. And it's this iPhone connected at-home blood pressure monitor. I think like one PCP visit, I had high blood pressure. I don't know why, but it's usually normal. But they sent it to me and I said, yes. They're like, can we send this to you? I'm like, yes, a free connected device. Sure. And it's interesting. I had some bugs, but I think it's been reliable since. I saw that they actually published a study earlier this year looking at the mobile users and found that actually they had people who used it, who needed it, did have significant reductions in blood pressure.
Yeah, so Hello Heart's a great company. We work with them and know them well, and I think there are lots of good examples of companies doing right in this spot. Without knowing anything about your blood pressure history, I would say you're probably not the person who needs it. And in 3 months or 6 months, that blood pressure cuff is going to become a doorstop in your house, and that's what happens to most of them. And so if that were invested in getting it to the patient who wasn't answering their text or email that said, do you want a free blood pressure cuff, because they were in the hospital or they were dealing with issues that doesn't let them easily say, oh, a free device sounds great. That's the person who needs it. And we've not done a very good job of getting those cuffs to the people who are going to really benefit from them.
Yeah. Well, and this is disconnected from the provider. So I don't know, certainly my health plan employs their own providers, but this is kind of disconnected from my normal flow.
So then, Jeff, the obvious big question that a lot of us, again, and maybe a big subset of this population isn't the target audience for a lot of this, but what about the Apple Watch?
So Apple Watch actually is another example to me of somewhat like GLP-1s, an amazing trigger for, back when 10 years ago, when it started bringing health metrics to bear on its devices, it has created a cascade of huge benefits in heart health specifically. And now other stuff, I think we're probably tracking all sleep and hearing and fall detection. It's really done a pretty amazing job. With regard to the heart, it brought heart metrics front of mind. I mean, we started this call with both of you saying that you've got devices telling you about your heart numbers. None of that would be the case if the
Sure.
Apple Watch didn't start measuring ECGs and heart rate and giving you heart rate variability. So I think they started a lot of this momentum. And the positive out of this is that we're looking at more data. We're finding trends. We are picking up disease sooner in its process. The negative to that is we're not sure if that's leading to better outcomes over time. Getting people anxious about cardiovascular disease 10 years sooner does not mean you're going to reduce heart attacks 10 years sooner. And so we need to find that balance of more information is not always better. And we want to make sure we're providing more information for the right reasons.
Jeff, that's really interesting because I think back to when this current wave of digital health really seemed to come to the forefront. And I think back to the early days of Rock Health's funding when Hallie and her co-founder Nate started that phenomenal organization. I remember talking to doctors and they would say, look, I don't want that data. I don't know what to do with it. Right? It was confusing. Not all of them are consistent. And now just hearing your answer to that prior question leads me to believe there has been a shift in the medical community around, hey, these tools can be helpful when it comes to measuring heart. So, love your reaction to that.
Yeah, I think that's well said and matches our experience. When we first started, we used to lovingly name a condition Apple Heart Syndrome when patients would call in by the hundreds and then the thousands saying my watch gave me an alert. I need an appointment. That's gone away, and now we're seeing that not only is the data better, but people are now do enough of let me triangulate this with my symptoms and my other testing that I've had to determine whether I really need a visit or an appointment or something's going on. So it has crossed that. It's crossed through, I think, to now provide pretty valuable information, and it's helping more than it's hurting.
What do you think about the new sleep apnea feature?
So I think about sleep all the time. Much like diabetes or cardiometabolic, sleep is on that same spectrum of cardiovascular disease. Patients with heart failure, for example, have 80% in some population risk of sleep apnea, and if you treat one but not the other, then you won't get better, and you really need to treat both. So sleep apnea is a hugely important, underdiagnosed, undermanaged condition that is very treatable if we find it. And if the watch is able to bring sleep testing, which historically has been very painful to get done. If you've ever gone to get a sleep test, it's no one's first choice of a weekend activity. And it's now has the potential to be done just like your Oura Ring when you're sleeping any routine night.
Yeah, I'd love to just double click quickly, Jeff, on sleep and its impact on cardiometabolic health. Hallie mentioned it at the beginning. You noted it as well a few times here. Can you educate our listeners just a little bit about the correlation between, sleep and cardiometabolic health?
Yeah, so sleep apnea is a condition effectively that it's caused by a multitude of things, but the way that I think about it as a cardiologist is that when you have sleep apnea, everything gets worse. Your metabolic health gets worse, your weight gets worse, your heart health gets worse, your arrhythmias, you're prone to arrhythmias. And so just like if you were managing, diabetes without working on your diet or without working on weight, if you're trying to manage cardiovascular disease without working on sleep apnea, then you're missing this huge driver of this condition. And the correlate is true. The exact opposite is true, that if you've got sleep apnea and you're not managing your arrhythmias or your heart failure or your obesity, then you're never going to make any, meaningful improvement in your sleep apnea. So it's a condition that the problem with it is that we for decades, we just weren't looking for it enough. We weren't managing it the right way. And the management was a lot clunkier than it is now. CPAP, for anyone who's experienced CPAP, which, for some people still has this image of this horrible device that lived on your parents' nightstand and gave you nightmares. It's different now. It's small. You can take it with you on airplanes. It's a lot less cumbersome, and
it's not as loud.
It's not as loud. You can sleep next to a partner with it. So it's a different age than it was a decade ago, both in the diagnosis and treatment of sleep apnea, and that's good. Certainly good for heart outcomes, but good for everyone.
Jeff, maybe just to take us home, we know, to eat less red meat. We know to exercise more. These are kind of some of the obvious things that we can do to improve our heart health. What are some other factors about heart health that we and our listeners can take with us into our everyday lives?
So I'll give my regular plug to get your LPA checked. So lipoprotein little a, which is think of it like a cholesterol marker that is more accurate than your other cholesterol markers. It's not routinely measured. And in this country and other countries, it is routinely measured. It's only a one-time test, so you only need to get it done once. But if high, it's an important indicator that you are someone who needs to take your cardiovascular health seriously and likely get evaluated for treatment sooner than you would otherwise.
I've got to go back and look at my blood test now, Hallie. Got me,
see if Dr. He's doing
the reverse. It's usually patients making doctors tweak out about data. Now I got to go the other direction as the patient take a look and see.
I'm sure someone does an at-home finger prick test like this, right?
It's coming tomorrow. It's not there yet, but it will be.
Okay.
Yeah.
Awesome. Well, this was really enlightening. Dr. Wessler, thank you so much for being here.
Thank you. Thanks, Hallie. Thanks, Michael.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.